but I want to talk about what I'm seeing. Now, she's wearing a V-neck. We do not see any accessory muscle use. None. There are no intercostal retractions or bulging. That's good. No neck muscles being used. So I've already counted her rate. She's 4 and 15 seconds, so she's 16. And she is Updick. Now, as I move around this way, I'm focusing on transverse and AP diameter. Now, AP is going to be 1 to 2 of the transverse diameter. Okay. Now, if you can move your knees to the wall. Now, when I say she's Updick, what I'm saying is that as she inhales, that's half of exhalation. So her IE ratio, inspiratory to expiration, is 1 to 2. Now at this point, I'm going to inspect the posterior spine. Now she doesn't have any scoliosis, no kyphosis, and no lesions, no integumentary lesions of note. Now we're ready for palpation. Now this is a little bit different than what the book focuses on because I'm really focusing on muscle groups. Now let me know if there's any pain. So the paraspinals for the cervical region are fine. And this is the paraspinal muscle in the thoracic region. Now I'm in the lumbar area, and so the paralumbar muscles are non-tender. Now I have already checked for lumbar edema and there is none. Now can you say 99 for me?
99.
Now here you go side to side.
99.
Now
99.
fremitus should do what?
99.
In the periphery?
99.
Does it louder?
99.
It should diminish, sure, exactly. Now, next thing I'm going to do is check for chest excursion. So inhale, exhale. And notice that my thumbs part and they return symmetrically. So that's good. Now I'm actually ready for percussion, my favorite. I'm going to start at the apices. I can actually hear you through my finger. Now, what I'd like you to do here for the first intercostals is find the vertebra prominens and then find an intercostal that you can really get your fingers between. Now, I've done this side, so I'm going to drop down 2 and go to the corresponding place. And notice that I cut my nails short because when we do the abdominal exam, boy, I don't want to have anybody with long nails. That just does not go in nursing. Now inhale, please, and hold it. Now notice what I'm doing. Exhale and hold it. Okay, so her diaphragmatic excursion is probably about 5 centimeters. Okay, and you can do that on one side. Great, thank you. Now, while I'm at it, I'm also going to check for CVA pain. So there's no costral vertebral angle tenderness. Now, can you breathe with your mouth open, please? Nice and slowly. One more time. Now, she has vesicular sounds here, 3-to-1 ratio, they're soft. Now I'm in the intrascapular area, and I expect to change. Oh, these are definitely louder. I've got bronchovesicular sounds with a ratio of 1-to-1. Now again, returning to the periphery, sounds are softer, 3-to-1, vesicular. Okay. Great. Now, no adventitious sounds, no crackles, no wheezes. Can you say E for me, please? Now, I'm going to do this if I suspect that she has consolidation. Okay, thank you. So the E to A would be sign that there is a what? Consolidation. Right. And remember how we talked about the cellular soup? All right. So there's no consolidation. There are no E to A changes. Now you may choose to do bronchophony or whispered petroloquy, I don't care. All right, now, could you turn around and lie down? Now this is one of the things I'm going to be looking for is proper positioning. So some of our people have long legs. Don't let the legs lie there. Now, you couldn't have worn a better shirt. Now, we've already checked the carotid artery in the sitting position, and I hope that nobody has venous distension when they're sitting up. That would be pretty serious heart failure or certainly volume overload. More typically, we're going to also look at the jugular venous distension in a supine position, 35 to 45 degree angle. Now, she has absolutely no distension. I can find her external jugular vein easily right here. Now, it pulsates, but it doesn't have that upward pulsation that the carotid does. Now, we also see a pulsation here, which is the internal jugular. And we know that this external jugular can distend very easily with Valsalva, with pain, and I don't want you to get tricked. Now the other thing is that when we measure the JVD, we need to find the sternal angle, raise a ruler that's calibrated, and we take the top of the column, and this doesn't even rise above the clavicles. So yours is 0. Yay! All right. Now, the other thing I'm looking at actually is I'm looking at pulsations at the auscultatory areas. Now, she has a light pulsation that I can see at the aortic and as well as the pulmonic area, and this is to be expected. So we inspect also in the AV area, in other words, the tricuspid and the mitral area, for what we call lifts or heaves. If the left ventricle lifts up and you really see a large, you might say, interface with the chest wall, big left ventricle, not good. In the epigastric area, right ventricular hypertrophy would manifest as a large lift. So when I talk about interface with the abdominal wall or with the chest wall, you'll find that the point of maximal impulse should be 1/2. Not as big as my fist, because when people have really big ventricles, you can see this move up. Okay, now, next thing I'm going to do is actually feel for pulsations. Now, most people are going to start here at the apical area. Now, when you do this for me, make sure that your location is accurate. So you need to find the fifth intercostal space. You're going to be medial to the midclavicular line by about 1 to 2 centimeters. Now, this is where we're going to be doing all our auscultation to start out with. Then I move to the tricuspid area, which is the fifth intercostal space, left sternal border. Urbs, which is at the third intercostal, left sternal border. Second intercostal space is the pulmonic, and this is left sternal border. Second intercostal space, right sternal border, is the aorta. And I feel pulsations in all those places. Now, which part of the stethoscope, and the patient can answer too, do I use to get normal sounds?
Diaphragm.
Okay, the diaphragm. So, what do I have here? Haha. Now, notice what I'm doing. I'm checking the radial pulse too at the same time. Now, her pulse is regular and it transmits to the radial artery. She's got a +2 radial artery here. Now I hear lub greater than dub, so I'm hearing lub dub, lub dub. Now this is the time when you actually get your radial pulse, or rather your apical pulse. Now for virtue of time, I'm going to move to the tricuspid area. S1's greater than S2. Urbs area, S1's greater than S2. Now, got to change here. Pulmonic area, S2 is greater than S1. I hear lub dub, lub dub. Now, I just heard the physiologic split as she inhaled. Now that was lub, lub on inspiration, and then it went back to lub. Now, at the aortic area, I hear the second heart sound louder, lub dub. Now I'm going to turn the stethoscope over to capture low-pitched sounds, would be S3 and S4. Now you get extra points if you can tell me what causes an S3 or an S4. Or maybe if I get really fancy, I'll drum you out a gallop. Now here I am going back. Now we know that gallops are heard at the tricuspid and the mitral area. Sometimes you can hear them in the Erbs area because they really are ventricular sounds, aren't they? So who can tell me what causes an S3?
Early diastole.
Yes? So it's caused by?
Early diastole sound.
Probably heart failure
Oh.
and volume overload because it's an early diastolic sound, meaning if the ventricles are already filled or overfilled, that little bit of blood that's just moving in passively during the first part of diastole causes this extra sound. So it's... Now, S4 was more what you were thinking, and that is the compliance issue. When the heart's ischemic, it gets stiff. Now, in order for the heart to really contract and deliver a good stroke volume, it needs to be elastic. So it's got to stretch and then recoil, stretch and recoil. Ischemia causes a very stiff heart. So hypertension, coronary artery disease, and an MI could cause this sound. Now here's lub, then dub, but that extra S4 comes right before S1. So that could be an extra point for you if you choose to do so.